Hello, everyone, and thanks for joining us today. My name is Kathy Bernard, and I'm the founder and president of the Save Your Skin Foundation. I welcome you to today's webinar's presentation on prognostic testing and what it means to ocular melanoma patients. Before we begin, a few logistics. All participants in the audience for today's webinar will be in listen-only mode for the duration of the session. There will be a question and answer portion at the end of the presentation. To ask a question, please type it in the Q&A panel, which you can access at the bottom of your screen. Please feel free to ask your questions throughout the presentation, and we'll do our best to answer them in the last segment. If there are any questions that do not get immediate answers, we will contact you with a reply and any discussion you wish to have after the webinar. This session will be recorded and will be available for viewing on the Save Your Skin Foundation's website and YouTube channel in both French and English. We will also send the recording to all who registered tomorrow. Now, it is my pleasure to introduce Nigel Deacon, who will be emceeing the webinar tonight. Nigel Deacon is a stage 4 ocular melanoma survivor, one of Save Your Skin Foundation's original board members, and a good friend. Over to you, Nigel.
Thank you, Kathy. Hello, everyone. It's my pleasure to be here tonight to introduce our presenters. Our first presenter is Dr. Katherina Alsina, the Associate Director of Scientific and Medical Affairs within Castle BioSciences Uveal Melanoma Division. Unfortunately, Dr. Alsina was unable to join the webinar live today, but I did have the privilege of talking with her earlier this week, and we will now listen to a recording of that conversation. Tell us a little bit about yourself, your background, and your role at Castle BioSciences.
Sure. I support Castle's Uveal Melanoma Division from our headquarters, which are based in Houston, Texas. I'm a scientist by training, and in my role at Castle, I spend part of my time providing support for the physicians who utilize our uveal melanoma tests, and the other part of my time driving uveal melanoma research initiatives. And I wanted to take a moment to recognize that we have a really incredible team of scientists at Castle supporting our research and development division. They work to validate all of Castle's clinically available tests through research studies. And that's really important because we want to ensure that patients are provided with the most accurate and actionable information possible.
Could you tell us a little bit about how Castle BioSciences got its start?
Sure. Castle was initially founded on a mission to improve care for patients affected by rare cancers. Our founder, Derek Matzold, recognized that there was this huge gap around how cancer patients were being treated, with clinicians relying only on the clinical and pathologic features that were available by traditional cancer staging. And so the company's vision was to provide more accurate information through our testing that would help doctors and patients make better decisions about their overall treatment than if they didn't have our test available. And so our first test was actually the DecisionDx test for patients with uveal melanoma. And so that's the test that tells patients the class of their tumor. And so our test is really how we got started in the molecular diagnostic space. But since then, the company has grown and has really evolved, and our scope has expanded to include tests for skin cancers like skin melanoma and squamous cell carcinoma, for Barrett's esophagus, and most recently for mental health disorders.
Wow. So today we're zeroing in on molecular prognostic testing in ocular melanoma. Tell us a little bit more about what molecular testing is and why it's important for a newly diagnosed OM patient to discuss this option with their doctor.
Yes, molecular tumor profiling is really leading the way for precision medicine. And I think most physicians who are treating uveal melanoma are very in tune with all these advances, and they're discussing the option with their patients. Castle's testing requires a tumor biopsy, and that allows us to analyze a number of different biomarkers in the tumor to determine its molecular signature. It's a very individualized type of tumor profiling, and that's important because it allows physicians to tailor their treatment and surveillance approach based on the patient's unique biology. And so in the case of our uveal melanoma test, it's important for patients to know that the tissue has to be collected before the tumor is exposed to any treatment, like plaque brachytherapy, for instance. And so timing is critical. We need a sample of the tumor in its kind of original state before treatment in order to get the most accurate picture of how aggressive it may be.
Terrific. Forgive the simplicity of this question. You used the term molecular testing. Is that the same thing as genetic testing?
Yeah, it's actually a great question because these terms, molecular testing and genetic testing, are many times used interchangeably to describe the type of testing that we perform. And they're not incorrect, but actually the best and most precise term to use is genomic testing. But I want to kind of go through each one. So molecular testing is really an umbrella term. Molecules can form DNA, they can form RNA, they can form proteins. And so the term molecular testing is kind of a catch-all, and it's totally accurate to refer to our tests as molecular tests. But if you want to get more specific, you can use the term genomic testing to describe Castle's uveal melanoma test, because those tests look specifically at the genome, at the DNA and the RNA. And then the term genetic testing is interesting. It's my least favorite. And it's not incorrect, but it is commonly used when referring to inherited diseases, diseases that are passed down through families. And so we try to avoid using that term when talking about cancer testing, unless, of course, there's an inherited component, which there sometimes can be in uveal melanoma, but typically there isn't.
That's very helpful. Could you tell us a little bit more about the Castle uveal melanoma tests? What exactly do they measure, and what kind of information do they give us?
We offer 3 different molecular tests for newly diagnosed uveal melanoma patients that altogether can provide a very comprehensive molecular picture of the tumor. The main test, our main test, is called DecisionDx-UM. That's the test that gives us the tumor class. And this test has been studied and validated across many studies over the years, including in a prospective multi-center study called the Collaborative Ocular Oncology Group Study, or COOG. And so that test works by measuring the activity of 15 specific genes that are within the patient's tumor, eye tumor, to determine the likelihood of that tumor spreading or metastasizing from the eye to other organs in the body. And the test, so the test result can be either class 1A, class 1B, or class 2, and the class 2 tumors have the highest risk for spreading. Now, I mentioned we offer 3 tests. All 3 of those tests can be run from a single tumor biopsy sample, so it's possible to get a lot of information from a very small amount of tumor tissue, which is great. And in the US, biopsies are typically performed using a very thin needle to aspirate or suck up a little bit of the tumor for testing. And so our platform can run all of the tests with just this small sample.
And how are the test results used?
Knowing the molecular class of the tumor can be very helpful to patients and to their physicians in planning their follow-up care. There are considerations about the kind and frequency of monitoring the patient will need, and whether the patient might be a candidate for certain treatments or clinical trials as they become available. And so while the DecisionDx-UM test cannot guide a physician toward a specific therapy, there are studies that have shown that the class result has a significant impact on the management of uveal melanoma patients. And so many ophthalmologists in the US who treat uveal melanomas are using molecular testing, and national guidelines, NCCN guidelines, recommend increasing the frequency of metastatic surveillance for patients whose test results show that they're at high risk of metastasis. But of course, the decisions around surveillance and treatment and other follow-up plans would always need to be made by the doctor and the patient.
Of course. You mentioned Castle offers 3 tests for OM. What about the other 2? Can you tell us a little bit about that, please?
Sure, we do offer 2 additional tests that can all be performed again from the same original biopsy sample that we use to run the DecisionDx-UM test. We can perform PRAME testing using a test called DecisionDx-PRAME, and we can perform DNA sequencing to identify mutations in the tumor using a test called DecisionDx-UM-Seq. So it's important to remember that the test that gives you the class result, DecisionDx-UM, is the only one of those 3 that has been prospectively validated and confirmed across multiple studies. The other 2 tests, the PRAME test and the sequencing test, are adjunctive tests. Their prognostic value is still under investigation, but they may be able to provide a more complete picture of the tumor to potentially help refine a patient's individual risk for developing metastatic disease.
Perfect. You partially answered my next question, but let's include it anyway. Could you tell us a little bit more about PRAME and the DNA mutations and why this information might be important to have in addition to the class result?
Yes, PRAME stands for Preferentially Expressed Antigen in Melanoma. And it's a gene that is usually not found in normal adult tissues, but in some cancers like uveal melanoma, PRAME levels are abnormally increased. So there's a lot of interest around PRAME because some studies over the past few years have found increased levels of PRAME in uveal melanoma tumors seems to be associated with riskier tumors that are more likely to spread. And so specifically, those studies have suggested that a class 1 tumor that is PRAME positive, so it has elevated PRAME, may be associated with an increased risk of metastasis compared to a class 1 tumor that does not express PRAME, a PRAME negative tumor. And so it's important to note the studies around PRAME were retrospective in nature, so they're not the gold standard for validating biomarkers, but there is an ongoing prospective study, a prospective multi-center study called the COOG-2 study that aims to prospectively validate PRAME. And so until we have the results of that study, we can't say for sure what the exact impact of PRAME status is on a patient's risk for metastasis. And then as for our DNA sequencing test, we do offer this DNA sequencing panel DecisionDx-UM-Seq that can identify mutations in 7 genes in a patient's tumor. So like PRAME, that test is optional, additional test. It can be run on the same biopsy sample as the other tests. And there are multiple potential applications of knowing the DNA mutation status, but researchers believe that identifying these mutations may help to not only refine a patient's prognosis, but someday help guide treatment decisions. But again, like PRAME, these mutations really require further validation before we understand their exact role in prognosis.
That's super helpful. Thank you. Now, what about patients who know their tumor class, but they don't know their PRAME status or their DNA mutation status?
Yes, we would like to inform patients that if they were tested in 2016 or later, our clinical lab may have additional tissue, residual tissue samples stored that we could go back to for PRAME or mutation testing. And patients can check on that at any time by calling our clinical services team. Maybe we can provide the contact info in a post after this.
That's terrific. Will molecular testing results help patients qualify for clinical trials?
It is becoming increasingly common for genetic information to be included as part of the requirements to qualify for clinical trials or for specific therapies. We know searching for clinical trials can be overwhelming and confusing. We have put together a list of currently recruiting trials specifically for uveal melanoma patients. We do this as a courtesy to the physicians that we have in our database. These lists are updated quarterly and are distributed, but they're also posted to our website under the resources tab, so they're freely available to anyone who's interested. But we have one list for patients who have been diagnosed with metastatic disease, so those are the advanced trials, and another for adjuvant trials for patients who have not yet been diagnosed with metastatic disease.
It's really interesting to see how the testing and the science are moving along together. What happens to biopsy material that is unused? Can it be saved to use as testing advances?
Typically, if all three of our tests are requested by the physician, then the biopsy sample will be totally used up, and there will not be any left over. However, we do offer an option for patients to have an additional biopsy sample stored in our tissue repository program, free of charge for a period of up to 5 years. And to benefit from that program, patients just have to discuss the option with their physician, understand any potential risks associated with taking that additional biopsy, and sign a consent that would allow us to store the tissue.
Super. This, I think, is a tough question. Sorry about that. What about patients who did not have the option to have a tumor biopsy sent for molecular testing?
Yeah. In the absence of molecular testing, the physician will likely estimate a patient's prognosis based on a very comprehensive clinical evaluation where they look closely at the clinical pathologic features of the tumor. So the tumor diameter, the tumor thickness, and other traditional staging factors can help to estimate the patient's prognosis.
Terrific. And the last question, there's a lot of research going on to try and advance our understanding of rare diseases like OM. What excites you about the most recent ongoing advances in the OM field?
Well, I think it's a very exciting and hopeful time for uveal melanoma patients and their families because there's so much active research going on in the UM space. And we are very privileged to get to work with some of the leading clinician scientists on research collaborations to help advance the field. And one of these is with the Collaborative Ocular Oncology Group. I mentioned before that they initially validated the DecisionDx-UM test, and they are currently working on prospectively validating PRAME and the DNA mutations that we talked about. And so that group, the COOC group, has grown significantly over the past few years and is now expanding to develop adjuvant clinical trials for patients. So it's a really exciting time, and we look forward to seeing those efforts materialize in the near future.
Thanks, Kat. That's absolutely wonderful. When you explain, it's quite easy to understand. Thank you so much.
It's a pleasure. Thank you.
Well, I hope you found that conversation with Dr. Alsina as informative as I did. If you have any questions about the information that Dr. Alsina shared with us, you can certainly ask them in the Q&A panel, and we'll be happy to communicate all questions to her after the webinar. So we're going to continue with Dr. Butler, and he's going to talk to us a little bit about what prognostic testing means for the healthcare providers who care for metastatic OM patients. Dr. Butler is a medical oncologist and the Medical Oncology, Melanoma and Skin Oncology site lead at the Princess Margaret Cancer Centre in Toronto and assistant professor of medicine at the University of Toronto. He's a physician investigator with an interest in the translational development of immune-based therapies for cancer patients. He received his MD from Yale University in New Haven, Connecticut, and trained in internal medicine at Johns Hopkins Hospital, Baltimore, and hematology oncology at the Dana-Farber Cancer Institute, Boston. After serving on the Dana-Farber staff, he joined the Department of Medical Oncology and Hematology at the Princess Margaret Cancer Centre in 2012. He's the clinical director for the immune monitoring team at the Princess Margaret Cancer Centre, where he focuses on the immunologic impact of anti-cancer immunotherapies. And he's a physician investigator with an interest in the translational development of immune-based therapies for cancer patients. He's been involved in the early development of several important immune-based therapies for cancer, including adoptive cell therapy and immunomodulators, including immune checkpoint blockade. He has a major interest in investigating the combination of standard and immune-based therapies as a method to address innate and emerging resistance to immunotherapy. Dr. Butler has been a great resource and friend to Save Your Skin Foundation for many years, and we're so pleased that he's the co-lead of the Ocular Melanoma Physician Task Force of Canada. Dr. Butler, you were here in time to enjoy Dr. Alsina's presentation. And I'm wondering if you would be able to respond in terms of, in a very simple way, do you prefer patients to come to you when they've developed metastasis with some of this information, prognostic testing? What difference does it make to your practice?
Okay, yeah, so I have, there was a great talk that she gave, and there are a couple of things, especially for the patient community, that people should be aware of that I'd like to provide some perspective. All right, so this is a slide that talks a little bit about the uveal melanoma and gives a little bit of perspective on some of the ideas that were being presented. One is that when a patient has their surgery or plaque brachytherapy for their uveal melanoma, the tumor sample is obtained by placing a needle into a tumor site. A couple of things that are important to be aware of. One is, on this slide that's shown here, we have several different uveal melanomas. This isn't the way it looks for a particular patient. This is a conglomerate of multiple patients, but you may have a large tumor that's at the base, as you see here. You might have a tumor that's found on anterior, but in any case, just a single needle is passed through this tumor when the plaque brachytherapy is performed. If a patient has an enucleation, there's more tissue. And you're able to do all of this molecular analysis just on these samples. On this particular slide, you'll see some words that patients may have heard about, BAP1 or SF3B1 or GNA11 and GNAQ. A few of these findings are helpful. So what she spoke about is identifying class 1 or class 2 uveal melanomas according to the Castle test. And to be quite frank, once you develop metastatic disease, it doesn't matter whether the test was class 1 or class 2, because you're dealing with metastatic disease at the time that the patients present. Now, there are a couple of additional bits of information. The further genetic analysis that she described, where you look at specific mutations that are present in the tumor, will have some help in management of patients with metastatic disease. And some of it has to do with the prognostic behavior of the tumors. SF3B1 mutations, we believe, are associated with more indolent course of patients. The patients tend to relapse later than other patients that have relapse. And we're beginning to believe that patients who have SF3B1 mutations have a slower growing type tumor picture compared to patients who have other more aggressive mutations. BAP1 is a mutation that's sometimes in rare cases passed down through families. It's also seen in sporadic cases that are not genetically linked. But in BAP1 mutations are associated with earlier relapse and perhaps a bit more aggressive disease. However, we'll see exceptions that prove the rule often, where you'll see different types of behaviors. So don't worry if you didn't have a prognostic test done when you were diagnosed with uveal melanoma. It probably won't have major impact on what we do if you develop metastatic disease. It really has a lot help in understanding how aggressive and how careful we necessarily need to be with the surveillance. That's the real role of the Castle test. If a patient develops metastatic disease, then we can do molecular analysis of the metastatic lesion and learn whether patients have specific types of mutations. I already mentioned the SF3B1 and the BAP1 mutation. There's also two very important, actually four very important mutations, the GNAQ, GNA11, CYS, LTR2, and PLCB4 mutations. These, the GNA11 and GNAQ is present in 95% of the cases. And these mutations are associated with sensitivity to new drugs that are being developed. And we're seeing some very exciting results with some drugs that are targeting protein kinase C. There was a recent press release by a company called IDEA that's showing some exciting results with their early phase study and where patients are having some benefit. Now, I thought that this slide might help in understanding a little bit of the biology, because I think if you really just restrict your eye to the top line, I think this gives a little bit additional information that can help. Patients who have just freckles in the eye will have these G protein, GNA11 or GNAQ mutations present in the melanocyte. And then additional mutations occur as that freckle develops and changes and then may become a melanoma. These mutations like BAP1 and other mutations are associated with more aggressive disease. And if you think about it, the tumor may have those new mutations occurring in some of the cells, but not all the cells. The tumor itself in the eye is probably quite heterogeneous. The great advantage of the Castle test is that it's looking at multiple different factors within the tumor, and you don't have to get every single tumor cell to understand all of the different subpopulations that might be present. That is at least the theory behind how that particular test works. But I wanted to mention that many patients in Canada have a different type of test performed. It's called the Impact Genetics test. And this is a test that's used in many different jurisdictions. Less in the US. This test is used more commonly in Europe and Australia. In fact, the group that does this test is in Ontario and receives samples from all over the world. Additionally, there are some groups that do the similar type of test in-house at the molecular labs in particular hospitals. And this test is different than the Castle test because instead of looking at different genes that are expressed within the tumor, it's looking at chromosome changes that are present in the tumor using a molecular probe. So it looks just at the DNA, not at the expression. She mentioned RNA. This type of test, the impact test, doesn't look at RNA, doesn't look at PRAME, but it does look and sometimes will perform sequencing. I mentioned SF3B1 before, and it also looks at GNA11 and GNAQ. These tests are done to confirm that the sample has tumor present within the sample. And then it looks at chromosomal imbalances of chromosome 1, 3, 6, and 8. And what we really are looking at are mutations, are imbalances in chromosome 3 or 8q. When you have monosomy 3 or the loss of one of the two in the pair of chromosome 3, that's associated with a higher risk of relapse. And when 8q is increased, that's associated with increased relapse. So if you have both monosomy 3 and 8q gain, that's particularly high. And when those are normal, even in a large tumor, there's a little bit less risk of developing metastatic disease. So the way I use these results, either the Castle test or the impact genetics test, is that it helps us decide how aggressive we want to be with monitoring patients after they have their primary eye procedure performed. Patients who have very thin melanomas or small uveal melanomas have a particularly good prognosis. In fact, Dr. Weiss would probably say that there are some patients who have plaque brachytherapy, and we're really worried about the changes that we're seeing in the lesion in the eye, but the lesion itself may not have progressed into a very aggressive cancer. And we treat with plaque brachytherapy, and if the genetic analysis is favorable, their chances of relapse is very, very low, and therefore the intensity of monitoring can be guided on symptoms and ultrasounds and other types of approaches that can be managed locally. For patients who have large tumors or small tumors with high risk features, we basically will monitor patients more intensively with scans in general, we're finding that every 6 months is adequate. Some of the guidelines will talk about every 3 months, and what is feasible in different jurisdictions will depend on access issues. But in general, for very high risk, large tumors, we'll push the monitoring initially to be more frequent. But for patients who have standard large tumors or concerning features, for 5 years, we'll do imaging every 6 months, and then after that, yearly to monitor patients. And the reason why surveillance is important is because we now have things that we can do to treat patients. In the past, we had very few options for patients. So there was a feeling of futility, that maybe it didn't really matter, and that what patients should do is enjoy their lives and not be tortured by concern about a scan coming up. What we're finding now is that we are developing treatments that are showing activity and responses in patients with disease. Apologies for some of the noise. But those responses are being seen more often in patients with smaller tumors. So a more aggressive approach with monitoring patients, I think, is of use, because then we can get patients onto a treatment plan when we identify a problem, and we both hope and we have some data to support that benefit from therapy is more likely if the tumors are small. There is this particular drug called tebentafusp, which was recently approved. About half of patients with uveal melanoma can receive this drug. What it does is it links the patient's T cells with the tumor cells and induces the T cells to attack the tumor. This is a little graphic that shows in a patient on this drug tebentafusp, the purple areas are T cells that are being drawn into the cancer following treatment with this drug. What I bring up here is the fact that this particular treatment, tebentafusp, even though it's received approval, has a very low response rate. Only about 5% of patients will have tumor shrinkage. that's significant, about 5% of patients. That's the patients here that hit below this bar of 30%. And that's certainly very concerning that this drug has a low response rate. However, there's also been data that's been provided that shows improved survival even for patients who have further growth of their cancer. What you can see here on the left is patients, percentage of patients alive being much higher than this control curve on the left, where patients were treated with drugs that were not as effective as tebentafusp. There's been a randomized study that's also showed improvement in survival compared to control. There's also, you see these curves called progression-free survival, where the drug doesn't look really that great because it's very similar to control. But as I mentioned, you can see some growth of the cancer, but still patients are living longer. So where it gets, this is a very busy slide. It's trying to identify which subgroups of patients do better with tebentafusp. And I just want to draw your eye to this thing called M1A. This is where patients have the largest metastatic lesion is less than 3 centimeters compared to 3 to 8 or greater than 8 centimeters. And you can see that this little bar here is closer to tebentafusp as opposed to a standard investigator choice treatment. And that's because the smaller tumors seem to respond better. Patients have a longer survival and higher chance of response with small tumors. And then this slide here was part of the phase 2, where we looked at patients who lived greater than a year versus patients who lived less than a year. And what we saw is that in both cases, between screening and the week 8 scans, we saw growth of the cancer. However, patients who lived longer had a leveling off and a slowing of the growth of the cancer, whereas patients who had worse outcomes, the tumor continued to grow at the same speed. And the other thing that you can notice here is that this thing called sum of diameters, which is basically a surrogate measure or a way to get a handle on how big the cancer was in these patients. The patients who did the best, that lived longer than a year, had smaller lesions, and there was leveling off or slowing of the tumor, whereas the patients who had larger lesions, the tumors continued to grow. So for me, what's meaningful about this treatments or these monitoring of patients is that it can identify patients who are at higher risk of relapse, and then we can be a little bit more intensive in the inconvenience of having MRIs or ultrasounds, the traveling that's required, the review of the scans, the anxiety that's associated with that, so that we can identify problems early rather than waiting for symptoms. For patients who have a test performed that shows good prognosis, we'll continue to monitor the patient regardless. However, we may have peace of mind, and we won't necessarily need to investigate as intensively as patients who have higher risk. So in my practice for the surveillance program, we're seeing patients with large tumors, and on that basis, we're monitoring them closely, even if they have good risk molecular testing. And in our center, we use the impact genetics test because Ontario does not cover the Castle test nor the impact genetics test, and the impact genetics test is much more affordable. So we're using that test. It's identifying patients to monitor, and we are finding patients at the appropriate time with small tumors to look at options for therapy. It's the patients with very small tumors that you think are very good prognostics. Those patients are the ones where these molecular tests are particularly helpful because if you identify that they do have some bad cells in that tumor, then you can upstage their aggressiveness in monitoring in order to avoid the possibility of missing a patient who requires surveillance.
Super. That's absolutely wonderful. You've helped, I think, you've helped us to understand that a small primary tumor is better than a large primary tumor because it may indicate it's a less aggressive form of the disease. And even when it comes to metastasis, earlier is better. For the registrants, we do have just a few minutes for questions, and you can pop them in the chat box. We do already have 2 questions. Dr. Butler, I wonder if you would be happy to tackle those.
Sure.
This person has a widespread metastasis in multiple locations, has tried immunotherapy, ipi-nivo, got into difficulty with it, which I think is quite common, and is now on prednisone to calm things down. But she's beginning to wonder if there are any clinical trials that would be available to her in Canada. And since I think you do more of them than any other doctor in Canada, maybe you'd be able to provide some information about that.
Well, so certainly for patients who have metastatic disease and don't know their HLA-A2 status, they should obtain that information. And it unfortunately is, we're just now dealing with the education to get access for patients to have the drug tebentafusp, which has been Health Canada approved. Its other name is Kimtrac. And so patients can receive that drug as standard of care, but the only patients who have the HLA-A2 marker will be eligible or will benefit from this type of treatment. So that's one thing that I would ask one's doctor about. And this is a new mode of action, a completely new type of treatment. So most standard oncologists would not necessarily be aware of what needs to happen. But I will say that in most of the centers in all of the provinces now have physicians who are aware of the drug and are working out ways to get the HLA testing, so you don't have to make your way to a center like Princess Margaret to have access to the drug. It is a drug that can cause some side effects that need to be monitored, and we've had situations where patients were eligible for the treatment, but the local hospital isn't set up to do the initial infusions, but will do the infusions at Princess Margaret for their first few times, and then they'll be able to receive their treatment locally on a weekly basis there. In terms of clinical trials, there are several groups around the country investigating brand new treatments in the phase 1 setting for uveal melanoma. I mentioned this new drug called darovasertib, which is a drug that is showing promise. Not all the data has been released, but there's been a press release that there's activity. It's just right now, previously untreated patients are eligible to receive that drug, but we do have a waiting list for when slots become available for patients who in the second line setting. So if I'm happy to do virtual consultations to get patients on the list for receiving this new drug that's showing some benefit, but it's still in early phase, and we're unclear of all of the options for or slots for that study. And then there certainly are centers in the US that have multiple different options that are available. And there are also phase 1 groups that may have a promising drug to try.
Super. That certainly sounds like good news in a field where a very short time ago options were extremely limited. This is a second part really of that patient's question. And she's wondering if, although she has widespread metastatic disease, if it would be useful to have next generation panel sequencing testing done to get more information and perhaps find some targets. What would your advice be on that?
We will, yes, as a matter of course, I always want more information than less. And it might provide something some information that you did not expect. And unfortunately, it depends on, I think one of the things we just have to be realistic about is that comprehensive next generation sequencing in uveal melanoma often tells us the basic minimum stuff that we already know, and that we end up not finding a new treatment option as a result. However, I do think that there's utility in doing the testing because we'll learn more. And also, I think that there's always a chance that you'll learn something that you didn't expect. For the current studies that we're doing, the molecular testing isn't 100% required, but can be helpful.
Super. Thank you very much. We're running out of time very quickly here, but I do want to take a moment to thank both Dr. Alsina and Dr. Butler for generously giving of their time to help us increase our understanding of the disease and treatments. And we especially appreciate, Dr. Butler, your very up-to-date information. So back to Kathy now.
Thank you again so much to our presenters for tonight. Nigel, as always, thank you so much. Dr. Butler, I don't know what else I can say, but you're amazing. And we are so proud to have you as a Save Your Skin friend. I think I can say on behalf of all the patients, caregivers, and physicians that will benefit from the information you shared, that we are truly grateful that you took the time to share your expertise and insights with us tonight. To all of those who attended tonight's webinar, a big thank you for joining us. Again, I'll mention that this session is recorded and will be available for viewing on the Save Your Skin Foundation's website and YouTube channel, as well as sent to all who registered. If you have any additional questions, please send them to myself at info@saveyourskin.ca. Thank you for watching. This ends the webinar session.